Hello, this is Neil Baum from New Orleans, and I want to talk with you for a few moments about some of the metrics we use to predict healthcare and compare that to the hand size of NFL quarterbacks. A recent article from the Wall Street Journal entitled, "Big Time Quarterbacks Have Small Hands." The previous assumption was that small hands of NFL quarterbacks result in fumbles and bad throws. And the size of a quarterback's hand was considered a useful metric when deciding whether to draft a college quarterback. The facts are that hand size on average of NFL quarterbacks is over 9.5 inches, and some of the Hall of Fame or Hall of Fame future Hall of Famers is in excess of 10 inches, where Patrick Mahomes from the Kansas City team and Joe Burrow from the Bengals have hand sizes less than 9.5 inches. So what is the solution that these quarterbacks with small hands use to manage the football? Football has its widest circumference at the center of the football and its smallest at the tip of the football. So those quarterbacks with small hands, as shown by Joe Burrow on the left, grip the ball closer to the tip compared to quarterbacks with larger hands who grip the ball closer to the centers. So what does hand size possibly have to do with healthcare? Well, I hope I have shown you the hand size does not necessarily predict success on the football field, and perhaps doctors are focusing on the wrong metrics when we are trying to assess men and women's health. For example, the BMI, total weight, glucose level, BUN creatinine, resting heart rate, and cholesterol may not be the appropriate metrics for measuring a patient's health. For example, following a radical retropubic prostatectomy, either with surgery or radiation, we commonly measure the PSA and the percent of men who have erectile dysfunction. The truth of the matter is that men are far more interested in being continent than being able to engage in sexual intimacy. Let's look at a measurement of patients' frailty. This is very difficult to quantitate, but two of the methods are to measure the grip strength of a patient, or the time for a patient sitting in a chair to get up, walk about 10 steps, turn around, go back to the chair and sit down. It has been shown that if there is a decrease in the grip strength or longer for men or women to get up and go, suggests frailty. The equipment or ergonometer that is used to measure grip strength can also be assessed very easily using a bathroom scale, and have the men compress the scale and measure their grip strength on the use of a scale. And this will give a good handle on the patient's frailty. Another metric that we commonly use is the resting heart rate. During an annual exam, it's very appropriate to measure the patient's temperature, weight, and resting heart rate. The basal heart rate may not be a gauge of a patient's overall cardiovascular health. It's far better to measure heart rate variability, as this correlates very well with longevity. The heart rate variability is the interval between the RR segments on a EKG. Patients with a low heart rate variability perhaps are out of shape experiencing increased stress, having more insomnia and other chronic illnesses. Patients with a longer heart rate variability are less likely to have cardiovascular disease. We commonly measure a patient's weight and BMI. Far better to consider is the waist circumference, which might be a better indicator for stroke, obstructive sleep apnea, diabetes, and cardiovascular disease. Perhaps the waist circumference is a better predictor of obesity and chronic diseases, better than the BMI or the total weight. Finally, let's look at the state of hydration. It is a myth that men and women should drink 8 glasses of water per day. The amount of water you consume is considered to be variable based on the age, the gender of the patient, the climate they are living in, and their activity level. It's far better to have a patient, particularly those with nephrolithiasis, to look at the color of their urine after exercise. The goal is to keep these patients well hydrated and to avoid hypovolemia. And the way they can do this is to look at the color of their urine. If it is pale yellow, that is indicative of good hydration. However, it's the color on the right side, which is darker, that may suggest hypovolemia. This is a far easier metric to use rather than measuring the specific gravity of the urine in these patients. Lastly, I want to talk about the transition from the office to telehealth. In the past, several years ago, the doctor often stated they had to actually see and touch the patient in order to properly manage the patient. The pandemic opened the way to care for patients at a great distance from the doctor. Before the pandemic, less than 10% of patients availed themselves to telemedicine. As of March 2020, there was a significant increase in telemedicine to over 70% of patients were using telemedicine to communicate with their healthcare provider. So the reality is that we can better care for patients without being in the same physical space of our patients or having to have them come to our office. The reality regarding telemedicine is that the toothpaste is out of the tube and it is difficult or impossible to put it back. So what's the bottom line? The size of a quarterback's hands in the NFL does not necessarily predict how successful they will be during a game. Perhaps healthcare, we are looking at the wrong metrics to measure health. Maybe the annual chest X-ray, EKG, cholesterol level, fasting glucose level will go by the way of measuring the hand size of quarterbacks. Maybe we can find new methods, new metrics for treating our patients. Well, I hope you have found this video helpful and useful regarding metrics used for assessing healthcare status in our patients. If you have any comments or suggestions, you can contact me at the email address, which I am showing you on this last slide. Thank you.